Today we are going to discuss about gastrectomy, or in simple word, we can say that it is gastric resection. So we will just look at the why this gastrectomy, in which condition it is required, what are the anesthetic consideration, what are postoperative complication, and then just I will briefly review a case. So gastrectomies are generally two types, whether it is total gastrectomy and partial gastrectomy. Then there is another type of gastrectomy, what we call is a sleeve gastrectomy, that is used mainly in bariatric surgery. So that's altogether a different subtopic. So I will not be going into that detail. Now, for routine gastrectomies, the indications are most commonly gastric cancer. And gastric cancer consists of adenocarcinoma in majority of cases. Then there are rare cancer as the GIST or gastrointestinal stromal tumors, lymphomas, carcinoids. On average, generally, in world, we don't have Indian data, but in US, almost 21,000 are diagnosed with gastric cancer annually. And out of that, more than 10,000 people die every year. And it is more, particularly in southern India, and very much common in eastern part of the world, that is Japan, Taiwan, etc. Initially, the 5-year survival rate were just 16%, but nowadays, with improved treatment, 5-year survival in from 1995 to 2005 is around 27%, and now some reports are coming out in last 10 years. It is almost around 40 to 50%. Not great, but much better than before. So, reason for this decreased survival is most cancer are diagnosed at the advanced stage, because there are no specific symptoms. When symptoms occur, generally cancers are at the advanced stage of the disease. So when we offer surgeries are usually offered in localized cancer, when cancer is not spread to any other organs or it is not metastatic. So there are two types of therapy. When in resect, we call operable or resectable cancer. First we resect and then offer the adjuvant chemoradiation. Or another thing is what we call is a sandwich treatment, where initially we try to control the cancer with chemotherapy or radiotherapy. After sometimes we do gastrectomies, and after gastrectomy also we give chemo and radiation therapy. Nowadays, more and more reports are coming out that sandwich treatment is much better than the upfront surgery and then chemoradiation therapy. However, we have to do some staging investigation before offering surgery that I will always discuss in subsequent slides. And at the time of surgery, because however we investigate, there are some disease or metastatic disease that may have missed in previous surgery. So before committing to gastrectomy or before taking an irreversible steps, we do certain steps. That is, we do by diagnostic laparoscopy to check that whether it is tumor is spread or any other vascular invasion, because whenever tumor is spread to blood vessels, generally it becomes a non-curable disease. Of course, we look for any medical contraindication to offer such a major surgery. Right? So pre-op evaluation should include the clinical examination for any metastatic nodes, whether it can be most commonly found in the neck or around umbilicus. Umbilicus we call the Burko's node. And detailed abdominal examination, chest X-rays to see for any lung metastasis, CT scan abdomen and chest to see any hidden metastasis, particularly in liver metastasis is quite common, because whenever such metastasis is present, generally the disease is already spread and it is non-operable. Then if you have facility, then endoscopic ultrasound, whether ultrasonographic machine or ultrasonographic probe, to be precise, is added to the end of the endoscope, and that will give you exact idea of how much the tumor is spread locally, how much, which layer of stomach or esophagus it has involved. So this is the latest technology, very useful in loco-regional staging, or we call it the T staging in TNM classification. First step for any gastric cancer surgery or before committing to gastrectomy is to undergo staging laparoscopy to define the metastasis which has not been found in imaging technically. In 20 to 30% of cases, diagnostic laparoscopy can find peritoneal metastasis, and by finding that you can avoid a morbid surgery, because in presence of metastasis, aggressive gastrectomy generally doesn't help. Also, you can take a peritoneal washing, because whenever peritoneal washings are positive, you can add chemo and radiotherapy accordingly. Okay, generally, as we said, for whenever we do gastrectomy for cancers or malignant tumor, generally there are two types of gastrectomy: total gastrectomy, where we remove the entire stomach, or distal gastrectomy, where we remove the distal part of the stomach. Now, total gastrectomy is generally preferred for upper part of the stomach. Why? Because generally, after removal of the tumor, you need a good margin. That is required 6 centimeter on the upper side and at least 2 centimeter below. Now, whenever tumor is in upper part of the stomach, it is very difficult to get a 6 centimeter of adequate tumor margin, so that the entire cancer tissue is resected and you can offer a better cure. So to get that margin, we require total gastrectomy in majority of cases with upper end tumor, and lower end tumor, generally we offer distal gastrectomy, or whenever we do not remove the entire part of the stomach, we call it a subtotal gastrectomy. Nowadays, most of the resection are performed laparoscopically, and of course, robotic is coming, so many surgeons operate robotically also. So these are the steps. Generally, we put a midline incision, particularly in open, and apart from incision, the steps remain same in laparoscopic, robotic, or open. First, the liver is retracted to open the right part of the stomach. First, omentum is removed, because I will discuss in subsequent slide. Good lymph node clearance is the best way to offer a long-term survival. We divide various vessels affecting the stomach, that is the short gastric vessel. Whenever postoperative blood bleeding occurs, it is most common from the short gastric vessel. That also we will discuss in the one of the complicated case that I have handled. You can have a splenic injury, left gastric ligation, because left gastric artery is generally very below the stomach. This is also a difficult source, and at this stage, massive blood loss can occur. Pylorus has to be resected, and lymph node dissection is performed. So whenever you have removed the total or part of the stomach, but you have to give back the gastrointestinal continuity. So generally, jejunum is attached to the proximal part of the stomach in subtotal or distal gastrectomy, or you have to attach it to the food pipe or esophagus in case of total gastrectomy. Generally, it is done by Roux-en-Y loop. Roux-en-Y is the common gastric reconstruction technique, and it has been actually popularized by a gynecologist, but it is most commonly used reconstruction technique in GI surgery. So as you can see, this part we have removed. The one part of the stomach, distal part of the stomach, is attached to the esophagus. We have removed the entire stomach, and then this is the distal part. Then after cutting, first we cut the intestine from here. This C end is attached. Sorry, C end is taken to the esophagus and joined, and then this part, this B end, is attached to the different opening in the intestine. That is known as you can see the Y shape. This is known as the Roux-en-Y technique. Same way, you can see in case of distal gastrectomy, part of the stomach is remain. Intestine is cut from here. This is already cut because we have removed this part of the stomach. The C end is joined to the stomach, and B end is joined to the new opening created is the D end. Again, you can see the typical form Y. That is why it is known as the Roux-en-Y reconstructions. Now, lymph node, any stomach cancer first spreads to the regional lymph node. That is why good lymph node clearance is very necessary. In gastrectomy, there are three types of lymph node clearance, whether D1, D2, or D3. D1 in just lymph node around the stomach is removed. In D2, apart D1, then there is a D1 plus, where we remove the lymph node surrounding the stomach as well as the lymph nodes in the area what we call as the porta hepatis, that is the area where blood supply to the liver goes. In D2, apart from surrounding the stomach, porta hepatis as well as lymph node near the splenic and pancreatic tail is also removed. In D3, all every vessel, during splenic artery, renal artery, many lymph nodes are removed. There are number of lymph nodes, station of lymph node. We say 1, 2, 3 number is given according to D1, D2, D3 is classified. But that would become very complicated for this lecture, I would say. But it is recommended that either you have to do D1 plus or at least D2 resection. D3 has not given any survival advantage in scientific studies. Now, postoperative mortality. Earlier, it was mortality is said to be 100%, but with improving in surgical and anesthetic technique, now postoperative mortality or death rate after total gastrectomy is 2%, and with subtotal gastrectomy is just around 1%. So it's a quite successful surgery. Of course, you need to have a good pre-op investigation to select the better candidate for surgery. You have to, because pulmonary complication or lung complication are quite common after gastrectomy. So you have to check for diseases like chronic obstructive pulmonary disease or asthma or any chest disease. You have to ask patient to stop smoking at least 2 weeks before surgery, because smoking will increase chances of pulmonary complications. So you should have a good chest X-ray. You should have ECG. You can see in this patient, there are multiple ST segment elevation. So you can see underlying myocardial infarction, coronary artery disease, and cardiac angina, something is going on. So this patient is generally not a good candidate for surgery. But in stomach cancer, many patients, because it's an obstructing kind of tumor, so they are not able to take good nutrition or fluid. So they may be dehydrated or hypovolemic. And these patients are likely to have more complications. So you have to maintain body fluid balance. If they are dehydrated, optimize them, rehydrate them properly, and then take for surgery. Second, as I said, the hypovolemia is there. So due to relative hypovolemia, your hemoglobin may be falsely elevated. So you have to check properly, correct the hypovolemia. Generally, blood loss for partial gastrectomy is around 100 to 500 ml. For total gastrectomy, it can be around 500 to 1 liter. So you have to replenish the blood. You have to preoperative hemoglobin level should be at least 8 or more than 8. Second, sometimes patient will have gastroesophageal reflux disease or GERD, delayed gastric emptying, or sometimes food content lower part of esophagus, that can make your surgery more complicated. So you have to check for these conditions. Right? This is the detail about anesthetic consideration, but I don't think it will help. But generally, it is preferred that on-table extubation is preferred. Some patient with COPD may require a ventilator in postoperative scene.